The story of Cinderella, the prototypical persecuted heroine, has been around for millennia. In 7 BC, it was Rhodopis, a Greek slave girl who marries the king of Egypt. In 860, a Chinese version stars Yi Shen, a hard-working girl who befriends a fish, or something, and a slipper's involved, I think. And then one of the most popular versions was written in French by Charles Perrault in 1967 under the name Cendrillon. That's when the whole fairy godmother pumpkin royal ball glass slipper subplot was added. There's a theme that runs through all these stories. At the end of the day, Cinderella ends up with that princess hat. It's time to add yet another subplot to this timeless fairy tale, because it's sketchy. A cone-shaped princess hat is a recurring symbol for the aortic valve, and just like that mitral valve, it can get stenosed, or it can get all regurgy and stuff. Let's start with stenosis. Aortic stenosis is, by far, the most common lesion affecting the aortic valve. It typically affects patients in the 6th to 8th decades of life. So, in this scene, the disease process will be embodied by the elderly crotchety stepmother, putting some serious stenosis on that aortic princess hat. What's her backstory, though? I mean, was she always this crusty? And what is that on her face? Well, it turns out that in North America and Europe, the most common cause of aortic stenosis is calcific degeneration of the aortic valve leaflets. Hence the calcium milk mustache on her upper lip. Her upper leaflet, if you will. Leaf lip. Get it? Yeah, you get it. Less common causes include valve damage from endocarditis, metabolic diseases, systemic lupus erythematosus. But for all intents and purposes, calcification should be the first thing that comes to mind when considering aortic stenosis. Dystrophic calcification of the valve leaflets involves endothelial and fibroblast cell death secondary to chronic hemodynamic stress or atherosclerotic inflammation. Yeah, I said cell death. Just take a look. This cranky mistress kills everything she touches, including dreams. See how that aortic valve is getting all necrotic? Calcification is one of the hallmarks of cell injury and death, left behind after any kind of tissue necrosis. So this is not just some kind of benign calcium crust forming here. This valve is undergoing permanent damage. It was once thought that calcification was just a normal finding caused by wear and tear on an aging valve. However, it's becoming increasingly more accepted that the underlying mechanism involves the same kind of vessel damage that causes atherosclerosis. So the same risk factors likely apply here, including hypertension, hyperlipidemia, diabetes, inflammation, all the stuff related to the progression of atherosclerosis. Notice that the red, gunky candle there looks just like an artery overflowing with atherosclerotic plaques. Histologically, dystrophic calcium shows up on valves as fine, gritty white clumps. See? Kinda crunchy looking. Stenosis will progress asymptomatically for years, but once it starts to cause symptoms of outflow obstruction, prompt valve replacement surgery is a must. This stage is usually reached in the 6th to 8th decades of life, unless you have a bicuspid aortic valve. Take a look at the mouth of Cinderella's horse puppet, strewn on the ground. The nose and lower lip kinda open to form 2 cusps. See? Well, the aortic valve is normally composed of 3 cusps, but in about 1 to 2% of live births, an anomaly leads to right and left cusp fusion. So you're left with only 2. And trust me on this, it looks just like the mouth of a hand puppet. So instead of the shear stress being divided between 3 leaflets, 2 cusps must bear the brunt of all that hemodynamic stress. This, coupled with the other risk factors for atherosclerosis, means that dystrophic calcification progresses even more rapidly. Hence the calcium-rich milk spill. These patients will require valve replacement 10 to 15 years earlier than patients with normal valves, sometimes before the age of 50. So aortic stenosis? Pfft, what's the big deal? The heart just has to pump a little harder, right? Well, yeah, for a while. See that conch shell headdress she's got going on there? At Sketchy, a conch shell like this is a recurring theme used to convey concentric hypertrophy. Instead of concentric, think conch-centric. When a ventricle is chronically pressure overloaded, like when it has to pump against a tiny stenotic aortic valve, the myocardium gets buffered by adding sarcomeres in parallel, like the concentric layers of that spiraling conch. This helps the heart preserve stroke volume and maintain cardiac output. Look for that hypertrophied left ventricle on echocardiogram. The normal cross-sectional area of the aortic valve is about 2 to 4 centimeters. An area of less than 1.5 centimeters is considered moderate stenosis. Less than 1 centimeter is severe. And less than 0.5 centimeters, now we've reached critical stenosis. In general, patients with normal systolic function rarely show symptoms until aortic stenosis is severe, and even then, some patients will remain asymptomatic. However, eventually the heart just can't take the pressure, and just like we illustrated in our heart failure sketch, that concentrically hypertrophied wall causes diastolic filling problems and a diastolic heart failure. So sad. Now she'll never get to go to the ball. As we've seen throughout this course, almost any time the left ventricle sees higher filling pressures, it gets translated to the left atrium. This can lead to left atrial enlargement and hypertrophy, which is depicted by the dilated upper left wing of our fairy godmother here, who's come to save the day. Who's come to save the... Looks like she's struggling a bit there. Yeah, a dilated atrium doesn't like to conduct properly, remember? So say hello to atrial fibrillation. Let the irregularly irregular signal coming from that wand remind you of the irregularly irregular heartbeat characteristic of AFib. As we'll see in a second, even a simple arrhythmia can cause the patient to crash. Let's illustrate the 3 classic clinical manifestations of aortic stenosis: heart failure, syncope, and angina. Heart failure usually presents as dyspnea on exertion or decreased exercise tolerance. Aw, look, Cinderella's mice friends are rushing to her aid. That one in the back, though. Definitely some exercise intolerance going on. There's another process going on here as well. Aortic stenosis patients have what's called a fixed cardiac output. Because of the stenotic valve, they're unable to increase cardiac output during times of exertion. Imagine this dim, heart-shaped flashlight here, just unable to boost its output any further, even in a time of emergency. This fixed cardiac output problem is also one of the reasons patients with aortic stenosis develop symptoms of angina. They're unable to increase cardiac output and supply the heart during times of exertion. Notice that we've sketched in our recurring angina anvil, evoking that characteristic chest pain and pressure. Angina also develops because that massively hypertrophied myocardium has a higher myocardial oxygen demand. And because of the hypertrophy, it becomes harder for the coronaries to perfuse the subendocardium. And finally, there's syncope. This we tried to convey by making the anvil sink into the ground. That sinking syncope feeling. Remember that these patients have a fixed cardiac output, so when they stand or exercise, the heart is unable to generate a compensatory increase in cardiac output to meet the new demands of the body. This includes the brain. Decreased perfusion to the brain will cause syncope. I want to bring your attention back to that atrial fibrillation wand as well, because even a simple arrhythmia like AFib can be devastating. Atrial fibrillation causes a loss of that atrial kick, which leads to as much as a 40% drop in diastolic filling volume. Well, that ventricle is already working as hard as it can to get blood past that stenosis, so even a small decrease in preload can cause a precipitous drop in cardiac output. This is why it's so important to avoid arrhythmias and tachycardia. Well, this story's really taking a turn for the worse. And to top it all off, we've drawn in the murmur lines of her harsh, pathetic sobs. The murmur of aortic stenosis is a unique one. On auscultation, it will sound like a harsh crescendo-decrescendo systolic ejection murmur at the right sternal border. It's called crescendo-decrescendo because the murmur gets louder as pressure and flow increase during contraction, then it gets quieter and disappears as the aortic valve closes. And remember, at Sketchy, whenever we want to convey an event that occurs during systole, look for that systolic spray. This time, a systolic spray of tears. As her cries echo through that fireplace, keep in mind that the murmur can sometimes be heard radiating to the carotids as well. And remember how hypertrophied that left ventricle is? Well, it's no surprise then that you might hear an S4 gallop right before that S1. This occurs when blood comes into contact with that stiff, hypertrophied, non-compliant ventricular wall. At Sketchy, S4 is embodied by a stiff wooden chair, shaped like the number 4. Now, some of these physical exam findings actually help us determine the severity of disease. We'll illustrate them up above the fireplace. Take a look. It's the evil stepmom's newest inspirational poster. Really just there to remind Cinderella that if she's ever caught being late to her post, she'll be punished. TARDIS and Parvis describe the carotid pulse. Because blood from the heart is impeded by that stenotic valve, the carotid pulse will be delayed, or TARDIS, and weak, or Parvis. Both are a sign of severe stenosis. Recall that the systolic murmur is described as crescendo decrescendo. Well, it turns out that the timing of the crescendo peak can help us determine the severity of stenosis as well. A later peak means a worse stenosis. And as you can tell by this photo from Cinderella's youth, she definitely peaked later in life. Just a late bloomer is all I'm saying. And finally, a diminished S2 heart sound is another clue that you're dealing with severe stenosis. After that S1 mitral valve closure, S2 indicates the closure of the aortic valve. In severe aortic stenosis, that calcified stenotic valve just doesn't slam shut as vigorously as it used to. In this scene, diminished S2 is depicted by that frame sitting adjacent to young Cinderella up on the mantle. What? She has a twin sister? Who's a princess? The evil stepmom will have none of that, of course, and has tried to hide all evidence of Cinderella's twin. Diminished twin sister to represent a diminished S2. Okay, at this point, I bet you think we're done talking about the murmur, but I just want to quickly mention how we can augment the murmur with a few maneuvers. To increase the intensity of the murmur, ask your patient to squat from standing. This increases preload, increases stroke volume, and therefore increases the amount of blood shooting across that stenotic valve. So as Cinderella sobs out that murmur, she squats as well. To decrease the murmur, do the opposite. You've got to decrease preload, and this involves something like standing from sitting or the Valsalva maneuver to decrease venous return. Or increase afterload with a hand grip maneuver. This will decrease flow across the stenotic valve. See? Her little friend here is standing, gripping, and doing that Valsalva. And just a tiny squeak. One last thing. See those crushed tomatoes? The high pressure and jet stream effects of aortic stenosis can wreak havoc on the red blood cells that pass through. So watch out for hemolytic anemia. You might even see some schistocytes on the blood smear. This is one of the indications for aortic valve replacement. All right, it's time to introduce Cinderella's stepsister, who's preparing for the big night with the prince. She's got that aortic hat on, her favorite dress, and she powers down one last cup of milk, just for good measure. In case it's not plainly obvious, she's going to embody all that is aortic regurgitation, when an incompetent aortic valve is causing blood to dump back into the chamber after each contraction. In the developing world, the most common cause of aortic insufficiency leading to aortic regurgitation is rheumatic heart disease, embodied, as always, by that flaky and delicious rhubarb pie. No, Cinderella, no, that's not for you. Dessert is for real princesses. Think back to our rheumatic fever bakery sketch, where we learned how a group A strep infection can cause your own immune system to attack the heart. Though the mitral valve is classically involved, in about 25% of patients, the aorta will also be affected. This can lead to both aortic stenosis and aortic regurg, the two main players of this sketch. Remember, rheumatic heart disease is a disorder that largely affects those from developing countries or areas of economic disadvantage. In developed regions, such as North America and Europe, one of the most common causes of aortic regurgitation is calcific valve disease. You remember dystrophic calcification, right? Well, we're bringing it back, as evidenced by the gratuitous amount of calcified milk spillage. It's the same process that occurs in aortic stenosis. This time, however, that calcified valve doesn't close properly, allowing blood to leak back into the ventricle. Aortic regurgitation is also commonly caused by certain pathologies that lead to enlargement of the aortic root. See how the stepsister's aortic hat is getting pulled open at the base like that? Dilated around her thick head? This, of course, is just a premonition of something else not fitting later on in the story, if you're picking up on my dramatic irony right now. Anyways, the aortic root is the most proximal section of the ascending aorta, right as it takes off from the aortic valve. When it dilates, it can stretch the aortic valve along with it, leading to regurg. Numerous etiologies can lead to abnormal dilation like this, and we'll illustrate a few of them behind her. Recall from way back in Sketchy Micro that tertiary syphilis can hit the cardiovascular system. This can lead to a dilated calcified aorta and that classic tree bark appearance on histology. Also, we made that aortic root there look really hot and dilated and inflamed to remind you of systemic rheumatic diseases that cause large artery inflammation, such as Takayasu and giant cell arteritis. Interestingly, ankylosing spondylitis, you know, that rheumatic disorder that causes a fused bamboo spine, can also cause sclerosis of the aortic root, leading to regurg. And don't forget the collagen vascular disorders, such as Marfan and Ehlers-Danlos syndromes, embodied by Marfan the Martian here. These disorders lead to abnormal connective tissue development in the aortic root, causing that thing to stretch and regurg like crazy. Our last example to illustrate involves direct damage to the valve, instead of the aortic root. See that heart lantern up there? It's our recurring symbol for infective endocarditis. This disease is always depicted as a flame coming from within the heart. We are causing direct inflammatory damage to the valve here. So let's turn up the heat, shall we? Infection-induced valvular damage leads to valvular insufficiency, especially at the mitral and aortic valves. In fact, heart failure due to valvular insufficiency is the #1 cause of death in patients with infective endocarditis. But the heart doesn't have to fail right away. As a matter of fact, in most patients, aortic regurgitation progresses in a slow and insidious manner, with symptoms showing up decades later. The heart tries to compensate, and it can actually do a pretty good job for a while. With all that blood regurgitating back into the left ventricle after each beat, there's an increase in end diastolic volume and pressure, leading to wall stress. The heart adapts via eccentric hypertrophy. Remember, that's when myocytes add in series, as depicted by the elongated myocyte sash on the stepsister's big dilated dress. So, as you can see, the chamber dilates to accommodate all that extra blood. Not only that, those eccentrically hypertrophied myocytes help the heart preserve systolic function for a while. Nice. So, with all that extra volume sitting in the chamber, along with preserved systolic function, the heart is actually able to increase stroke volume and send all that extra regurgitated blood right back to where it came from. With the increase in stroke volume comes a subsequent increase in cardiac output, and with each forceful beat, the arteries are really feeling the pressure. Take a look at the other stepsister. So excited to go to the ball that she's jumping on the, oh man, is that a waterbed? Oh, I always wanted one of those when I was growing up. So freaking lucky. What I really want you to focus on is that bulge in the end of the mattress. Increased stroke volume leads to an increased systolic pressure reaching the arteries with each contraction. Notice that it bulges down as well. That's to represent diastolic pressure actually lower than normal in between each beat because of all that blood regurging back into the ventricle. Overall, this fall in diastolic pressure combined with an increased systolic pressure means a widened pulse pressure, sometimes as much as 100 millimeters of mercury, which means you'll see blood pressure values like 160/60, for example. With a pulse pressure that high, you can actually see it on physical exam. A Corrigan or water hammer pulse is caused by the rapid filling and then collapse of blood vessels as the heart ejects a massive amount of blood that immediately regurges back to the chamber. Just think of hammering down on that waterbed. So lucky. With such massive bursts of blood flow, patients with aortic regurg will sometimes have a characteristic head bob referred to as Valmusset sign, as depicted by the head bobbing on that doll with each bounce. Pulsations and capillaries of the lips or nail beds may also be present, referred to as a Quincke pulse. Again, it's all about that pulse pressure. Now everyone's favorite part, the murmur findings. The murmur in aortic regurg is an early diastolic murmur. It's described as a blowing, decrescendo murmur best heard at the left sternal border in the 3rd or 4th intercostal space. Hear that? It's diastolic. Thus, it's heard right after S2. And it's sketchy. If something is diastolic, you know we'll sketch in those recurring diastolic diamonds. It's an early diastolic murmur because blood immediately dumps back through that incompetent aortic valve during diastole. And it's called a decrescendo murmur because of that noise it makes. We try to convey that decrescendo shape in those murmur lines. But you can also imagine draining that bottle of milk there. A glug, 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 decrescendo. Remember how dilated that left ventricle can get? Well, it's no surprise then that you might hear an S3 gallop right after that S2. This occurs when blood comes into contact with the blood left over in a dilated floppy ventricular wall. At sketchy, S3 is embodied by an S3 slushy. All that blood just sloshing into that ventricle. Know what I mean? Well, that about does it. In aortic stenosis, listen for that systolic crescendo-decrescendo of tears, reverberating up those carotids. In regurg, an early diastolic decrescendo of milk. Stenosis of the valve causes pressure to build up in that left atrium, leading to AFib. And be careful, because a fixed cardiac output past that stenotic valve means that you can precipitate angina and syncope during times of exertion. In chronic regurg over on the right there, look for eccentric hypertrophy to increase the volume of that chamber and boost cardiac output, to send all that regurgitated blood back toward the aorta where it belongs, also causing those characteristic pulse pressure physical exam findings in the process. Hey, this is only the beginning of the story, kids. Don't worry, just wait until that fairy godmother gets that wand going. Then we'll see who's partisan and TARDIS. You know what? Joke's on you. I've slept in a waterbed, and the lumbar support is crap. Enjoy.